Welcome, everybody. I hope everybody has been enjoying the day. I know I certainly have, and I'm very excited to be here with Sean. This presentation is Beyond Stigma, Stigma, the Opioid Epidemic, and Opportunities for Change. I'll introduce myself. I'm Kirsten Dixon. I'm a family doc here in Toronto. I work with CAMH as well as Inner City Health Associates here in the city. All of my work is community based and shelter based. So in the shelter system in this city.
Hi.
Sean.
Sorry, I'm Sean LeBlanc from Ottawa. Hopefully, not everybody's so tired of seeing me already. I'm a person with lived and living experience. I am a community researcher and a board member of both the Canadian Association of People Who Use Drugs and the Ontario Network of People Who Use Drugs. And this was a really great video. I really recommend people check it out. It was a really great, inclusive, very equitable project, and I think we're quite happy with it. So.
Sean, I just want to make sure, like, you can't see the slides right now, eh? Okay, so there we go. Perfect. Nice. Thank you. Thank you, everybody. Okay, so we'll get started here. Hang on just a moment. Neither Sean nor I have received any form of commercial support, so we have no conflicts of interest to let you know about. Sean has already introduced himself, as have I. We have no potential bias to let you know about. We do, though, want to, before we get started here, just acknowledge a larger team who Sean and I have been working with on some stigma-related projects. I will, in a couple of minutes, put a link into the chat for a video that we've already completed, looking at stigma as it relates to opioid use and seeking treatment for pain. But we want to acknowledge our colleagues, Abby Sood, Jacqueline Myers, who's a pharmacist in Saskatchewan, Kirsten Ellis McDonald, who is an NP in Nova Scotia, and Pam Sabioni, who is a researcher in the field of substance use disorders. Along with Sean and I, that was our team for the original video, and we've got a larger and even more exciting team working on some future projects. And as I said, I'll stick that link in the chat in a moment. So Sean, I'll hand it over to you.
Thank you so much. So we do have some learning objectives for today. First would be to appreciate the complex and dynamic nature of stigma, specifically how it relates to opioids, to understand various ways in which stigma operates systemically, that it's supposed to serve people who use opioids from both the overt to the covert. Also to appreciate the imperative for addressing opioid-related stigma, and hopefully to gain a little familiarity for some strategies in addressing stigma. If you folks wouldn't mind, we'd love if you could please introduce yourselves in the little chat boxes there, and maybe just mention your practice setting or where you work, and one quick way of describing stigma that you see in the work that you do, I think would be very helpful to us all. I'm a straight white guy. I believe I've only been stigmatized from my drug use, but regardless of that, it can be really powerful, and it can be a really extreme barrier to people accessing treatment and just trying to get better. I'll give it a minute that we go into our first case study that we can talk about a little bit more. So as you see in our slide, Mr. A is 63 years old. He's been treated for opioids, chronic pain diagnosed for 3 years by their family doctor. The doctor diagnosed him with opiate use disorder and referred him abruptly to a methadone clinic. I've been there before. He feels angry, rejected, and ashamed. He hesitates to return to see his family doctor to discuss his worsening pain. So once he's at the methadone clinic, this Mr. A tells the front desk staff, "I don't belong here. I'm not an addict." And unfortunately, there's a real divisible line between people who are seeking methadone for physical pain and those who are, accessing it for other types of pain. Mr. A resorts to using a pharmacy across town where he hopes someone will see him standing in line. It's hard to get to work on time, but he doesn't dare share anything with their employer for fear of being fired. And I've been in that position before, having specific lineups for people who use methadone, people always looking at you strange, even pharmacists basically engaging in that type of stigma. Here's another case that we would like a little bit of discussion about, if possible, please. It's Mrs. B, who's 27. She's brought in emergency services after being poisoned by opioids. She's been to the emergency department 3 times in the last week, and for basically the same concern. She's advised to follow up at the hospital she goes to, the RAM clinic, and the emergency doctor asked her, "Why didn't you go? This is going to kill you, right?" And to me, that really resonates because I recently spent 8 years with our local inner city agency, taking people specifically to the hospital and helping them to navigate the healthcare system. And a lot of them really do start in emergency care. Obviously, the patient does not respond. She's been sleeping on the street for the last month, and she lost her housing and support of her family. She tried once to get to clinic, but it was too late. On other days, being preoccupied with getting to OW, finding a meal, going to the drop-in. People would never normally associate having an addiction to opiates as using up a lot of time. You'd be surprised as the amount of time and energy it both takes. There's obviously a mounting sense of hopelessness, and she begins to wonder to herself, why bother? So if you wouldn't mind, please putting into the chat if there's anything specifically that stands out to you in the 2 case examples that we used. If there's any similar scenarios that that kind of bring to mind to you, and maybe any differences, please. And finally, in what ways do you see stigma operating in these scenarios? And we'll just give that a second before I go back to the esteemed doctor.
Here, so thank you for sharing here. So I see there's a comment here. In either case, did the healthcare provider discuss the person's needs and feelings? Yeah. So I think these are very much examples of things being done to patients and not for people. The first case stands out as self-stigma expressed by the client. Yeah. We're going to talk a little bit more about self-stigma. It's certainly a very powerful experience for people who are experiencing it.
And if I could just interject, myself, when I was using opioids, I always felt that I beated myself up enough. I didn't need people in the medical system to do it for me. And it's amazing the amount of services you won't access because of that stigma. Sorry about interrupting you there, Kristen.
Not at all. No. This is we encourage conversation here in this presentation. There'll be lots of opportunities to come back to these cases and have a bit more of a conversation as we come to the conclusion of the presentation. So have a think about these things as we go through our next few slides, and we'll be coming back to things at the end. So to get started, we really want to talk about this concept of stigma and start with a definition of what is stigma. Stigma has been written about as a concept in the sociological literature for several decades now. Certainly a lot more recently around substance use disorders and specifically around opioids. But it was Irvine Goffman who kind of like the first most notable discussion of this concept of stigma in his book published in actually in 1963. The book was first published. He defined stigma as an attribute, behavior, or condition that is socially discrediting. And he went on to further define stigma as an experience that dehumanizes the individual based on their social identity or participation in a negative or undesirable social category. And he conceived of these experiences as causing a spoiled identity. This concept of spoiled identity has been contested, I think, for pretty obvious reasons in more of the recent discussion around stigma related to opioid use. But that was kind of his early conceptualization of stigma. More recent writing about stigma has kind of moved beyond the individual, the impacts on the individual and the individual experience, to conceive of stigma as really operating within a power structure. So Lincoln Phelan defines stigma as the co-occurrence of labeling, stereotyping, separation, status loss, and discrimination. And they further point out that for this process to occur, power must be exercised. So what we're seeing here in like this creation of a power dynamic, there has to be an in-group defining what is in and what is normative, and also of course defining an out-group and what is not normal or what is deviant from the norm. And these of course are socially constructed ideas of what is desirable and undesirable, what is normal and not normal. So of course we have some groups, experiences, characteristics that are socially acceptable, and others that are deemed not socially acceptable. So I think it's pretty clear, given this framework that we're developing, how long-standing beliefs and attitudes in our society about drug use, and specifically around opioid use, stigmatize people who use opioids, and perhaps more importantly for our purposes here, the extent to which stigma informs clinical and organizational practices when it comes to service provision for people who use opioids. Of course, we also need to appreciate the intersectional nature of stigma, by which I mean that opioid-related stigma intersects with and is compounded by other stigmatized identities. So of course, we mean identity characteristics like race, ethnicity, indigeneity, gender, sexual orientation, socioeconomic and housing status, as well as age. And it's because of the pervasiveness of stigma and the stigma experience, and the impact on multiple life domains, that there have been arguments made for stigma to really be considered an independent and fundamental cause of population health inequalities, or an independent social determinant of health. I think COVID unfortunately provides us with a very stark illustration of the compounding nature of stigma. Of course, it was very clear prior to COVID that opioid-related harms disproportionately affected communities that were also experiencing poverty, income equality, and other forms of inequality. And with it here in Ontario, and I'm sure it's true across the country, within weeks of the pandemic starting, we saw an increase in opioid-related harms, and specifically opioid-related deaths happening in those same communities. And of course, these communities were also disproportionately affected by COVID. Looking at the intersectional nature of stigma, this also has it has implications for strategies aimed at addressing stigma and reducing stigma. We know from evidence looking at stigma related to other health conditions that multiple stigmatized identities need to be recognized when we're looking at solutions. We know that interventions that address just one health-related stigma are rarely result in long-term health improvements, and don't really do much to address social inequality. I think it probably comes as no surprise that substance use, specifically substance use for its psychoactive effects, and use that seeks out pleasure and relief, are highly stigmatized experiences in this society and in countries all around the world. There's a WHO study done across 18 countries that found that illegal substance use is the most stigmatized social condition across those 18 countries. And this is more stigmatized than having a criminal record. The use of alcohol and having an alcohol use disorder was ranked 4th on that list. Health and disease stigma, of course, are pervasive, and we see multiple examples of this in healthcare. But we know that stigma is higher or more likely to be present when a person is perceived to be at fault for the health effects that they're experiencing as a result of substance use. Stigma is also likely to be higher if the condition that they're experiencing is perceived to be under their control. So moving on to opioid-related stigma, which I think gets very interesting, and we see how complex, dynamic, multifaceted this concept is when we start looking specifically at opioids. We move far beyond these ideas of fault and control. McCradden and colleagues talk about the ambiguous identities both of opioids and of people who use opioids. So what they're talking about here is this contrast between concepts of opioids, say, being beneficial medicine while at the same time being harmful drugs. So we get into like legitimate uses of opioids and illegitimate or socially unsanctioned uses of opioids. And of course, these are not stable concepts across time. We can think like quite recently in terms of healthcare to times when opioids were much more liberally and freely used by healthcare providers to treat all sorts of conditions, of course, specifically chronic pain. Whereas now, the prescribing of opioids is much more restricted and sanctioned. And this, of course, changes the way patients who are receiving this treatment are perceived by the medical community. So people have gone from deserving patients with chronic pain conditions to patients who are often perceived as being, difficult or complicated or in other ways undesirable. Of course, we still see a distinction even now between pain patients and the care that those people receive and deserve, and versus the care provided to people who are experiencing an opioid use disorder. So we see this distinction between kind of legitimate clinical complaints and illegitimate clinical complaints. Some people are seen as being credible, others seen as uncredible or seeking care for non-credible reasons. Here, and we'll move on to, of course, stigma related to opioid agonist therapy. Stigma against methadone may be the most pervasive and prevalent type of opioid-related stigma. And again, here we see this contrast between ideas about the treatment being legitimate and medically sanctioned and something that should, in fact, decrease stigma. Where at the same time, methadone often, entrenches stigma, further stigmatizes people, further marginalizes people when they seek out care. Of course, we also see this play out in kind of the locations and the availability of clinics providing opioid agonist therapy, the models of care that are present at these clinics, and how prescriptive and restrictive they are when they're experienced by people who are seeking care. Of course, this also plays out in pharmacies where people are often separated out from other patients. We know that separating out of methadone patients often increases perceptions about the dangerousness of those patients by pharmacists. And many people who are receiving methadone at pharmacies often feel like they're treated differently than other clients at a pharmacy. So finally, we get to stigma and the opioid epidemic. And I'm referencing here an article published in 2017 by Daniel Buckman, Pam Leese, and Aaron Orkin, who very eloquently lay out the case for stigma and the opioid epidemic not being two parallel processes, but really there's a symbiotic relationship between these two things. The stigma and the epidemic are co-constructed. And I think most importantly, what they're arguing for here is the importance of addressing stigma in all of the ways that we create to address the opioid epidemic.
Sorry. As well, this is basically how stigma operates. We mentioned before, it could be both overt and covert. It comes in a macro or a structural type of form, a meso form, or more so in public, or micro, which is interpersonal. And just personally speaking, it can be really basically very small. I've got track marks on my arms, and just having a specific look from a nurse when I was going for a blood test basically kept me from wearing t-shirts for 10 years. So the stigma itself isn't necessarily right in your face. Sometimes they can be hidden and really damaging, obviously. There are also multi-levels of strategies are required for addressing stigma. So as Kirsten mentioned earlier, people with gender issues, people with different races and stuff like that, it's basically the strategy. Oh, sorry, just let me start again. The stigma is compounded for people. I deal mostly with people living in a shelter, so they're dealing with the stigma of not having a place to live. And then if they're a racialized person, they're dealing with the stigma of that, and then also the stigma that comes with using opioids. The first one we mentioned was structural stigma, and that's around laws and policies governing the use of opioids. Um, Personally speaking, I've never been a criminalized person until I used drugs. Um, it was amazing how detrimental that was to both my health and my quitting said drugs. And thankfully, I believe there is a real push for decriminalization and other more progressive policies right now. There's also a huge amount of underfunding for treatment of people with opioid use disorder. I couldn't echo that even more. People trying to seek counseling or associated services in regards to the opioid use disorder. Another issue is understaffing and low pay in frontline work. I was mentioning this morning about going and speaking to a counselor at a CAC per se, and basically getting out all your traumas and so they can understand, your issues and whatnot. And then because they're in such a precarious working environment, pretty soon they'd be replaced, and then I have to basically repeat all of my traumas over and over again, and that eventually stopped me from seeking that kind of treatment. There's also separation of treatment for people with OUD. I think that really rings true too. It seems to be like almost a hierarchy. People on buprenorphine, people on methadone, people on safer supply, and these divisions are only creating even more harm. There's also a lack of support for novel treatment and harm reduction strategies. One that comes to mind for me, I really benefited from AccuDetox. Anybody who's not specifically aware of that, it's basically 5 needles in the ear, zoning out to some hippie music for 20 minutes or so. And I found that really helpful. Unfortunately, the person that was providing that service, basically the funding got cut. And despite several of us who were really benefiting from that, we lost it. The language of stigma can also be really powerful. One thing that stands out for me is a lot of people, including people who use drugs, use the word clean in regards to when they're not using or not. And that to me is a really good example of stigma, because to me it basically says that those that are using would be dirty if those that aren't using are clean. And a really great thing about this project was the involvement of people who've lived and living experience. Unfortunately, at a lot of times we're added at the end of a project. I call it like the 10% rule, where at the end of a project, someone is just basically there so a box can be checked and consult in a very limited way. Public stigma would be another type of stigma, probably the one that's most detrimental to me. It's very punitive and exclusionary clinical policies and practices. Limited access to care, fragmented and poorly coordinated care. For example, I see a doctor specifically for my methadone. I'm on a really low dose right now, and anything else I have that's wrong with me medically, I have to go to another doctor. And I think that coordinated care or lack thereof is something that's really preventing people from, realizing the potential of us being as healthy as they want to be. There's also a lack of consistency, which has been really bad. There's different ideas about what is better for people. It could be buprenorphine, it could be methadone, it could be abstinence-based. Also, the language around it and public support. And I think most people are very well-meaning, but the language is really detrimental. I remember the first public event I ever did, and it was myself and this doctor. We had an event called Overdose Awareness Day. It's at the end of August, and they had her with all of her titles and everything. It was really great. And then on mine, they had this huge, 3-inch headline, junkie. We are not what we do. We're more than the sum of our, consumption. And I think that's being missed a lot of times. Interpersonal stigma, self-stigma. So as I mentioned before, most people who use drugs, specifically opioids, beat themselves up enough. I don't think anybody was a child and said, yeah, I want to be a junkie when they grow up. Life happens, trauma happens, and unfortunately, people deal with it in different ways. A good example of that is also family members, the stigma associated from that. So I've recently reconnected with some members of my family, but during my drug use, they would have absolutely nothing to do with me. And that stigma to this day still really hurts. It's a lot of years of my not changing as a person or anything. I was a good person when I used opioids. I think I'm a good person now. um, and stigma from family members is very pervasive and maybe even some of the most damaging. As I mentioned earlier, the language, people even that are providing services have, dealt with me like when I was in withdrawal or something, like thinking that I could smoke a joint and basically get rid of my withdrawal. I think the public knowledge is a lot better right now, and I think people aren't stigmatizing themselves as much. But I just think the big thing that we're trying to get through in this presentation and through our video is how stigma basically creates such a huge barrier for people accessing the healthcare that they deserve and have a right to. I mentioned earlier the knowledge, attitude, behaviors of healthcare professionals and other frontline workers. Probably the one reason why I'm here right now is that I had a doctor who put up with my shit. He didn't ever judge me. He didn't ever punish me. He basically did what was best for me and my health. Unfortunately, a lot of that comes with a lot of burnout as well as compassion fatigue. Another personal example, I was outreach worker for 8 years, taking people who use drugs to hospitals, court dates, and stuff like that. I recently turned 50, and I just couldn't do it anymore. I was, falling asleep at night crying. There's so many people that we've lost in this horrible epidemic, and I really feel bad, quote unquote, turning away from them. But it was something I needed to do for myself because I would have been one of those numbers of people too, I think. Oh, I'm sorry, Doc. No, I've got two more. Addressing stigma. I'm sorry, folks. This is my third presentation of the day, and I'm really burnt out. I apologize.
It's okay, Sean. Sean, can could I just add a few things
Please
about
do.
the
Please do.
here? Wait, I'm gonna go back here. I guess maybe I'll start from the bottom and work my way back. But burnout and compassion fatigue, we included this here not because this is like a manifestation of stigma, nor is it nor is it kind of like independently a cause of stigma, but certainly it's clear, to the extent that there is some evidence for this, that burnout and compassion fatigue are certainly identified by frontline workers as being barriers to being able to engage in stigma informed care, and to be able to continue to engage in care that is often very, very challenging, emotionally challenging for people. And certainly as we are hopefully coming out the other side of the pandemic, and we are dealing with burnout on a massive scale for people who are involved in care provision for people in all parts of our system. I think this is something that we're really going to have to address on a systemic level, or we're going to lose. We are already losing really good people who just can't do the work any longer, and there needs to be kind of better systems in place to address this issue for people. I also think it's interesting how like language kind of cuts across from systemic all the way through to inter and intrapersonal stigma. So language used in policy documents put out by the government, in media releases, informs how the public perceives services that are being provided, and informs public support for services. And of course, language used in individual interactions, we know has a huge impact on how people perceive the care that they're being offered, and how it makes people feel about themselves. We also chose to order these things very specifically this way because a lot of stigma interventions that are available right now target kind of the interpersonal stigma, like target kind of the knowledge, attitude, behaviors of healthcare providers and frontline workers, and those certainly are uh, extremely important and make a huge difference. But those things are only going to go so far if we're not also able to address systemic stigma within our larger systems and stigma within ideology around the use of substances, the use of opioids, and how we provide services for people who use opioids.
Well put. When people go and actually access and watch a video, we used a stigma monster, and I think that really sums up a lot of the things that Kirsten was just talking about in regards to stigma, how it can be so overwhelming and pervasive on very many different facets of society. One way to stop stigma, obviously, is to address it. There's many strategies to address opioid-related stigma. I think a lot of it is be what I call equitably inclusive, and that's to include people with lived and living experience at all levels, including peer support. There's the 10% rule I'm always talking about, and most projects I've been involved with is basically getting a person with lived or living experience in opioid use to read a document or basically sign off on a project. And to me, it just seems like so a little specific box can be checked, or people can feel in some way that they are being, inclusive when the inclusivity is not really equitable in any sense. The structural stigma that Kirsten was speaking so very well about in regards to policies, our laws, I think there's been some very positive changes lately, i.e. the decriminalization movement and whatnot, but the stigma has been around for a lot of years, a lot of decades, and I think it's going to take a long time, unfortunately, to really eliminate said stigma. We also need to account for the intersectionality of stigma itself, where it meets, how it affects some more than others, and how it affects some populations more than others. We also need to incorporate ongoing evaluation and research, and I think this is really important too. I'm a community researcher right now myself, and initially a lot of the research was just, as I mentioned, being there at the end. But it's projects like this where I was involved from the very start, people like me, I really think is going to produce the most effective and positive ways to address stigma and all of the damage that it does. We also need to provide more meaningful education, which is targeted. I've spoken at a lot of different places, from Parliament to CHCs. I think a really good example is not being able to provide any type of education to our young people. I've always wanted to go into high schools and whatnot and speak. Unfortunately, because I'm a harm reductionist and a person who uses opioids, I believe a lot of those invites were never actually put through because of the stigma itself. And what is always very important, of course, is support and funding for frontline workers specifically, and supports to address the burnout. I mentioned where I was in frontline for years, and the amount of supports for people that use drugs was really, really lacking. There was no debriefing, there was no insurance, and it was 50 weeks a year of just the most dramatic, and stressful work all the time. And a lot of times people who use drugs are at the very front lines, and I think they need to be supported in every way possible. Sorry, go ahead, get off.
Sean, can I just wanted to add a little bit in here about the points about education, given kind of the focus thus far on strategies to reduce kind of the stigma at the interpersonal level. There's also better evidence now for what sort of education is meaningful and produces good outcomes. So there's this concept of contact-based education, which of course includes people who have lived and living experience in education, but I mean, education, we also understand it's not, I mean, as I think nothing about any of this can be a one size fits all model. Education has to be targeted. So education that's effective, say for medical students is not the same kind of education that might be effective for paramedics or first responders, might not be the same education that's going to be effective for people who are like making funding decisions about healthcare programs. We do know that education is not effective. It's just if it's just like a one-time thing, it has to be kind of an ongoing thing, or there has to be kind of follow-up sessions or opportunities to reflect back on education that's been provided, providing opportunities specifically for healthcare providers, providing opportunities in practice to reflect on care that's being provided and reflect on individual patient encounters is an important part of helping providers to develop some better strategies around understanding their own biases and their own approaches to patients. So I like in terms of ongoing evaluation and research, that needs to be a part of it. This understanding that just because a program model gets developed or an intervention gets developed, we have to be on the lookout for kind of unintended consequences of programs. So say like programs that target education for medical students around educating people around substance use disorders. At times has the effect of people develop a better understanding of what constitutes a substance use disorder, but they also develop kind of more pronounced ideas around kind of like perceived dangerousness of those patients and a distancing from those patients, which is not what one would expect from education being provided of that nature. So we need to be mindful around unintended consequences.
Well put. There's an ethos we use in the drug use advocacy movement called "Nothing for us without us," and I think all education should basically be formed around that specifically. And I think the greatest potential is always reached that way. And then finally, some promising directions, as I mentioned before. There's a really great movement in regard to family-centered treatment. There's a group that I work with very often called Moms Stop the Harm, and they've just done phenomenal work. Really great advocacy, fantastic allies, and we couldn't do it without them. So, secondly, I mentioned before the detox, the acupuncture detoxification. There's a lot of multi-service programming around to holistic directions. People need health care, people need food. It doesn't matter if you're able to support someone with their opioid use disorder when they're going back to the shelter and sleeping every night. So I think we need a lot more funding, a lot more services at very many different levels. And part of that would be cross-system collaboration. I'm not sure what community you all live in. I'm in Ottawa, and there's so much duplication of, frankly, a lot of ineffective services. I think when people get together and actually communicate, not just on an individual level, but an organizational level, that's when people who use drugs, and specifically people who use opioids, are going to be actually helped. And to go along the ethos of nothing for us without us is both mentoring and peer support models. And I think that really needs a lot of work. I know a lot of jobs, at least up here, they're just dropping people who live in lived experience into, working at supervised injection sites or doing outreach, and not providing them with the mentoring or the support that they need to be effective. And that has been really harmful to a lot of my friends, people relapsing, people actually passing away. I think we need to be cognizant of the pressure that's out there. I know when you're basically emerging from your addiction or whatnot, you really want to help people that you care about, just like anything. But along with those advocating, you really need support to do it, because those who've already faced so many levels of trauma and whatnot need the support. And I really think it's not really there right now. Back to you, Doc.
Thank you, Sean. And you'll see at the bottom of the screen here, some of these concepts are coming from this document, Mothering and Opioids, Addressing Stigma and Acting Collaboratively, put out by the Center for Excellence in Women's Health in BC. It's a very interesting document. I certainly recommend having a look at it if you're interested. It's a hopeful document. They're outlining program models that incorporate concepts like family-centered treatment and cross-system collaboration that are effective for people, that are allowing people to access care in culturally safe ways, in harm reduction focused ways, in trauma-informed ways. They're describing services specifically for Indigenous women who are using opioids and who are pregnant and or parenting. And the cross-system collaboration they're talking about is bringing together services like child welfare services and healthcare services and housing services, and systems that, at times are often working at cross purposes and maybe perceived to be not working together for people, and they're bringing those systems together and working collaboratively to support people. And having some really good outcomes. These, of course, are smaller programs, and they're very specific, targeted to specific groups of people. But of course, like recognizing that the experience of opioid use is very different for different people, and the services need to address the needs of specific groups of people. So at this point, we're gonna go back to the cases that we introduced at the beginning. We'll read through the cases again, but as we read through the cases this time, and we're gonna ask, hopefully, if people I feel comfortable using the chat. Very interested to hear people's thoughts about the cases. So, are there ways in which you now perceive stigma to be impacting these patients that perhaps you hadn't previously considered when we first introduced these cases? Are there ways you think that stigma could be reduced in these scenarios, whether it's like on an interpersonal level or on a larger structural level? And of course, perhaps a little bit later in our conversation, very interested to hear from folks whether you have any examples of policies, practices aimed at reducing stigma that you're employing in your own work setting. So let's go back to the case of Mr. A here, and I think, Sean, I'm reading this one name. So just to remind everybody, so Mr. A, he's a 63-year-old gentleman. He was treated for a chronic pain diagnosis for 3 years by his family doc, but then suddenly diagnosed with an opioid use disorder and abruptly referred off to a methadone clinic. This whole experience has left him feeling angry, rejected, ashamed, and he's pretty hesitant to go back to the family doc to discuss his now worsening pain problem. At the methadone clinic, he feels pretty alienated, tells the front desk staff, "I don't belong here, I'm not an addict." And he also resorts to using a pharmacy far away, doesn't want anyone to see him standing in line. It's hard to get to work on time, but he's very avoidant of talking to his employer about any of this because he's pretty sure he's going to get fired. So maybe we'll take a couple of minutes now just to let people respond. Are there things you're seeing here now in terms of how stigma might be operating in these scenarios that maybe you didn't perceive initially? Okay, so there's a comment here: stigma impacts all aspects of life. Yeah, certainly. I think that. I mean, obviously, this is very simplified version of what might be happening in somebody's life like this, but yeah, we're seeing it act at several levels, and somebody else is pointing out kind of macro, meso, micro. What? Oh, and this is a really interesting comment here. The main theme is that stigma is a trauma event. That's a really interesting comment. Certainly, I think we can see in this scenario here, like this is a pretty awful experience for this patient. We know chronic pain patients often feel quite ostracized, alienated, abandoned by the healthcare system when something like this happens. Certainly, that might be perceived as being traumatic. Maybe I'll just point out here too. Any thoughts? Any thoughts about his comments here about like I don't belong here. I'm not an addict. Have folks seen that play out in their practice settings? I mean, yeah, I mean, as a provider, I've certainly seen this happening. I often I struggle to figure out how to address this with patients. I mean, certainly somebody else overhearing a comment like that in a waiting room. This is now we're dealing with the impact on this gentleman and on people in the waiting room.
It seems to me too that perspective is largely systemic, excuse me. The system tells him that he's different because he's not using opioids for the reasons that I use them for. He's using them for quote unquote real reasons. And I think that's a pretty large difference and unfortunately a very divisible one.
There's some conversation in the literature, some discussion in the literature of this kind of like, even within the group of people using opioids, like the stigma occurring within the in group is very powerful and can be quite detrimental on people and have big impacts on people's likeliness to continue accessing treatment. Um, and this idea that some people are more deserving of a type of treatment than others.
I think I think the problematic use that can happen to everybody is also a very resonating point. I grew up in a military family. I was almost in the military myself. I never in a million years would dream that I would be an intravenous drug user. I remember when Kurt Cobain died of an overdose and thinking, that would never happen to me. No way would that ever happen to me in a million years. Unfortunately, I wasn't able to deal with my trauma in a very healthy way, and life happens, and I became what I most feared. And I think a lot of that is because of the stigma I had and the stigma I had towards myself.
Thanks, Sean. Maybe we'll here. Let's move on to our next case here, and then we can kind of come back to a larger conversation. Sean, do you want me to read out the case again?
I can do it if you like. It's up to you.
Okay.
So
You go ahead.
all right. Mrs. B, 27. She's brought in emergency services with opioid poisonings, overdose slash. She's been to the emergency department 3 times in the last week for basically the same issue. Each time she's been advised to go there, the hospital tells her to go to the Racket Addiction Medicine Clinic. She was there one day, and the emergency doctor tells her, "Why didn't you go? You know that this is going to kill you, right?" And I just think, having been in that situation before, you don't really see the absolute pervasiveness of that issue. A lot of things come up. You've got to feed yourself, you got to find shelter, you have to find opioids so you're not going to be sick. And I just think a lot more empathy and a lot more understanding in situations like that, specifically in emergency departments, would be really helpful. Anyway, in regards to the doctor's comment, Mrs. B does not respond as she's been sleeping on the street for the last month. She lost her housing and the support of her family. She tried once to get to the clinic, but it was too late. On other days, she's been preoccupied with getting Ontario Works, with finding a meal and a shower. She feels a very mounting sense of hopelessness, and wonders to herself, why bother? And I think that's really important because you get to a point, pardon my language, but people get the fuckets. And I have people that I care very much about. They still have that. Why would they bother with all this work and stigma and trauma and violence and whatnot? Because it's a lot easier just not to deal with it, frankly. And having been someone who did that for 20 years, I can totally resonate with that.
Sean, you've pointed this out several times, like in our conversation today and in other conversations we've had, like the extent to which self-stigma impacts people. I don't think, like, as a care provider, I was aware of like how how powerful a force that was for people, nor was I aware of, like, to the extent to which many people experiencing an opioid use disorder identify their family as being like the most kind of like powerful force of stigma in their lives. So, whereas I would have thought it would certainly be interactions with the healthcare system, many people identify it actually being their families, that it's a more traumatic and a more powerful experience.
Yeah, and I think that's a great point. Personally, my I guess appearance or how I was shown to my family was so much more important than how I appeared at the hospital or whatnot. As I mentioned before, I was away from my family for over 20 years. There's still most members I've never been reconnected with, and that was specifically and only because I was a person who used opioids. I turned to opioids because there was a lot of things I couldn't deal with, different traumas that I went through in childhood and whatnot, and as I think and I hope that our video and this presentation is getting through is that it can happen to anyone, and to show a bit of empathy. Self stigma to this day is still something I really deal with. That's my partner's biggest concern about me, is that I still stigmatize myself because of my drug use. It's amazing how long it can last and how actually absolutely can be. So we got a really good quote here. To me, this is an example of the way that healthcare providers insist on the individualization of health. It's poor practice and causes so much harm. Do you want to talk to that, doctor, since you're a doctor?
Yeah, of course. I Rachel, maybe I just wonder if to I wonder if you could explain a little bit more about what you mean about the individualization of health. I wonder if maybe, like, I hope I'm not misinterpreting. Please tell me if I am. Like this, what's kind of being represented here is this kind of like one size fits all, like just kind of like forcing care on people. Like, oh, there's this clinic, but it only operates on these days at this time, and like, why didn't you go there? Whereas like care that is individualized and recognizes individual people's needs would hopefully be a lot more helpful to somebody. So like co-located care, so somebody doesn't have to show up on a different day at a different time, and care that understands that what might be helpful for this person right now is access to a warm bed and a meal, and some financial supports, rather than focusing on the substance use per se. I'm just looking at your comment here. A person's challenges are at the system level, not within the realm of her power. Yeah. Thank you. That's very eloquently put.
Interesting enough, as I mentioned, I've been on methadone for about 10 years. I'm almost done, but it wasn't until I was able to get week-long carries at the start of the pandemic where I was really able to start to heal and really be a part of my own treatment. I've never done better. I was able to split my dose, as opposed to I'm working 9 to 5. I can never get in for a urinalysis. I was always trying to work around getting to the pharmacy in time, as Kirsten mentioned earlier. And ironically enough, it was just letting go of those proverbial liquid handcuffs that really allowed me to realize my potential and finally become a happy and quote unquote productive human being. And we have about 2 minutes left, I guess, if there's any last questions or comments or concerns. I think this is really great. They blame the victim rather than the responsibility that is shared and further exacerbated by a need to see ourselves as healthcare providers, separate neutral entities, like the ability to be anonymous and bullies. Perhaps this is strong. I don't think so at all. Would you like to address that, Doc?
I mean, yeah, like this is again, we're seeing problems play out at multiple levels here. At the at the interpersonal level, very obviously, like this why didn't you go, and like telling people that this is going to kill you, as though like there's this perception that people don't care about themselves and their health and their safety. Is a very like this very like normative concept of what a person's life experience should look like, and yeah, I mean, this blame the victim, like that way of framing it is exactly what's happening here, and certainly how it's being experienced by the patient in this scenario. You see, like, kind of the circular nature of how all of this is operating is that it further reinforces this kind of like, well, why try kind of like experience for people, and then healthcare providers, like, are further likely to see people as not trying hard enough, when in fact the problem lies far outside the realm of what is perceived to be happening here.
I was really lucky personally. I had a doctor who never ever judged me, never ever punished me. He, I knew I was a mess. He knew I was a mess, but he was just there to support me in any way he knew how. And frankly, that saved my life. So if there's any message I can get through to you today, would be to that. Just a bit of empathy and a little bit of inspiration, and people can do pretty great things. You have any last words, Doc?
I don't have anything else to say. I certainly I think maybe we have like 1 minute here. We're happy to take any questions or last comments. And thank you, Sean. It's been a privilege.
I've been a total mess. I'm sorry to everybody. Thank you very much, Kirsten. I appreciate that. This is my third presentation at this conference today, and I think I did too many. Having this cheesy man cold doesn't help either. So I just appreciate the kindness and whatnot. So thank you all.
It's truly been a privilege. Thank you to everybody for participating. We really appreciate it.
Please check out the video. It's really quite fantastic, and we're both confident you'll really like it.
Yeah. Okay.
Take care, everybody. Thank you.
Bye.